Good evening to all the aspirants present here and to all the doctors. Today's topic we have here is case-based discussion on DKA, where our organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Pari, and Dr. Asif Iqbal. The case examiner that today we have here is Dr. Rekha Das, who is also a dean and principal at Acharya Harirar PGI. Also, she is a consultant in Shanti Hospital, Cuttack. Also, we have here is Dr. Akhilesh Tandekar as a case examiner. He is HOD Depth of Critical Care, Workhard Hospital, Mumbai. And the case presenter we have here is Dr. Shalini Ranjan. And the moderator we have here is Dr. Asif Ahmed, who is a head consultant and HOD Critical Care Medicine, Tata Main Hospital, Jamshedpur. Over to you, ma'am, Dr. Shalini Ranjan.
Good evening, everyone.
Good evening.
Hi, good evening.
So, good evening. Let me come in, Dr. Shalini.
Yes.
I'm Dr. Asif. Yeah, as already introduced by Ms. Fatma, and welcome to each one of you, the examiners, the organizers, and all the participants who are here. So, what we are going to take through is what we want actually is a case that would be discussed, primarily presented by Dr. Shalini. A case of a diabetic ketoacidosis, I think one of the most common of the complications we see in an emergency or an ICU setup. So that is what will be looked after here. And once she has presented the case, then it can be taken up for questions, how to proceed regarding the clinical features, the diagnosis, differential diagnosis, investigation, and management. I think the examiners would do that for all of us. So, Dr. Shalini, you can take us through the presentation, and then I'll open it up for the examiners, Dr. Rekha and Dr. Akhilesh. Right. Please go ahead. Thanks.
Good evening, everyone. I will be presenting a case summary. We got a case. He was a 22-year-old male student. He was brought to the emergency department with a history of cough with scanty expectoration and low-grade fever from last 2 days and altered sensorium since last 1 day. He was a known case of type 1 diabetes on insulin since childhood, and he had given his friend has given a history of recently skipping of insulin doses for last 15 days due to some examination or stress. He had a family history of positive. His father was a known case of type 1 diabetes, and he's on mixed start insulin 30/70, 22 unit and 18 unit twice daily. On general examination, patient was febrile with the temperature of 100.1 degree Fahrenheit. Pallor, icterus, clubbing, cyanosis, lymphadenopathy, edema, everything was negative. He was slightly tachypnic. His pulse rate was 134 per minute. It was regular and low in volume. Blood pressure was 92/48, and respiratory rate was 34 per minute with rapid shallow breathing. CNS wise, he was E2, M4, M5, V4. He was irritable, obeying commands. CVS S1, S2 normal, and crepitations was present in right lower zone in mid axillary line. On per abdomen examination, it was soft and vowel sound was present. His airway he was Malampratti grade 1. So we sent all regular, all routine blood investigations, which include arterial blood gas, routine blood CBC, kidney function test, liver function test, serum electrolyte, serum ketone, urine ketone, HbA1c, random blood sugar, CRP, blood urea nitrogen, and radiological examination was chest X-ray and ultrasound abdomen. So his TLC was slightly raised. It was 14,600. HbA1c was 7.6. Serum ketone was 6 millimole per liter. Creatinine was 2. I'm just mentioning the positive findings. Serum creatinine was 2.2 milligram per dl, and blood sugar level was 453 milligram per dl. His arterial blood gas was pH was 7.24 with PaCO2 239. Bicarb was 10. PaO2 95, anion gap was 20, and serum osmolarity was 315 milligram per dl. This was his chest X-ray. It was showing right lower zone haziness.
Well, Dr. Shalini.
Yes, ma'am.
So this patient has been brought to the emergency department.
Yes, ma'am.
Yes. So how will you know, how will you diagnose this patient at the outset that
Okay.
it's a case of DKA? Okay.
Ma'am, according to American Diabetes Association, uh, his initially his sugars levels were high. 453 was his sugar level. So he was mild tachypneic, dyspneic. So it was we can go to, and uh, he was following all the criteria of guide of which character which is diagnosed, which we make a diagnosis of a DKA. So according to American Diabetic Association, blood sugar level should be more than 250 milligram per dl, pH less than 7.3, and bicarb levels less than 15, and anion gap more than 12. So he was uh, fulfilling all those criteria. So we can think in a we can go with the DKA. It's not a provisional diagnosis, but we can go with the, and ketones were positive.
Okay. Would you have taken any history of the patient? Was it
Yes, history. He was a known type 1 diabetic since
Yes. When you are diagnosing a case of DKA, so a very relevant thing is, would you have asked for a history of the patient because the patient was unconscious or obtunded? So
he was irritable, drowsy, obeying command. He was E3 V4 M5, ma'am.
yes, the patient was brought by some attendant, or who brought the
His
patient?
his friend had brought the patient.
So the friend gave you any, did you ask the friend about any relevant history, or you
Yes,
just
ma'am.
to examine the patient?
Ma'am, he was on insulin, but his friend gave a history of skipping insulin doses in last, because of his upcoming semester exams, in last 10 to 15 days. That was the history given by his friend.
So what do you think could have triggered this condition of the patient?
Ma'am, insulin deficiency. Uh, uh,
What are the bedside tests you did immediately, which
Okay, arterial blood gas was done immediately, and blood sugar was done immediately. So blood sugar levels were high, and ABG was suggestive of uh, high anion gap metabolic acidosis.
So what is the emergency in this patient to admit into the ICU? What are the indications that you need to admit this patient to ICU, or would you prefer to keep this patient in the emergency department?
Ma'am, as he was little irritable and drowsy, I think he should be observed. Close monitoring should be required, and immediate sugar volume resuscitation should be started with sugar close monitoring and regulating blood sugar levels.
In your setup, what are the immediate tests that you do on a patient when the patient is brought to to the emergency department in an unconscious state? What are the bedside tests you do immediately to get some clue as to the diagnosis of the patient?
In this case, urine, we have sent a urine dipstick for ketones.
Certain bedside tests which will give you a clue immediately in
Ma'am, blood sugar,
1 2 minutes you get all the reports that will give you a
blood
clue.
sugar, and arterial blood gas.
Laboratory test, sending the blood sample, sending for ketone bodies and all that. No. So what is the basic, when the patient is coming to you in obtunded, what is the basic test that you do? There in the emergency unit bedside to get an immediate result, or whatever clue as to what the patient has presented or the probable diagnosis is.
Ma'am, arterial blood gas is the first thing we start once we receive a patient, attach monitor. The first thing we do is we send up ABG. We do a blood sugar. We we'll do
What
a
is
ECG.
what is the quickest test of knowing the blood sugar level?
Okay. Bedside, ma'am, the glucometer.
Yes. You do a hemoglucometer test.
Yes.
Okay. And you there itself in an emergency, most people have their blood gas machine there itself to know the
Yes.
diagnosis immediately. Okay.
Yes.
What other thing? The clinical things parameter that you immediately look at. Within 5 minutes, you get a diagnosis, presumptive diagnosis of when the patient is coming to the emergency. These are the lab tests you talked about, a few bedside laboratory parameters. But what is other clinical factors or
We
the
will start by general examination. We'll start by general examination, a clinical and vitals. All will attach monitors. We'll start with, we'll see the vitals. Is the patient tachypneic or blood pressure? Is he maintaining blood pressure? Is he hyperventilating? What is the respiratory rate of the patient? Because if patient is coming with DKA, he might be having Kussmaul breathing, that is rapid shallow breathing. Then temperature.
why patients
And
have breathing?
yes, ma'am. Sorry.
Why do patients have Kussmaul breathing?
Ma'am, it's a compensatory for acidosis, which has been because of this ketotic. It's a compensatory mechanism to regulate pH.
So what is characteristic? Do you get Kussmaul breathing in other diseases or you get only in diabetic ketoacidosis?
No, in any acidotic, even lactic acido in
How will you differentiate that from that of DKA?
ma'am, other parameters which will be going towards diabetic.
No, in this particular DKA, the Kussmaul breathing is something different from that of the other metabolic acidosis patient.
Okay.
What is so characteristic about DKA, but Kussmaul respiration or breathing?
Fruity odor and
Why do you get a fruity odor?
because of ketone present, because of the presence of ketones.
What are these ketones?
There are basically three type of ketone: beta hydroxybutyrate, acetoacetate, and acetone. So in blood, it is maximum is ratio is high concentration is it of beta hydroxybutyrate. Normal value is 3:1, but during DKA it can rise as high as up to 12:1 is the ratio. Beta hydroxybutyrate is to acetoacetate, acetone.
So this patient, what was the clinical finding in this patient that was giving you a clue about DKA before you got a report of ketone bodies presence in the urine?
Ma'am, according to that American Diabetes Association, the criteria we were getting, according to blood gas, pH was less than 7.3, and bicarb was 10 in this case. So it was also fulfilling the criteria, as well as anion gap was 12, more than 12, and blood sugar was more than 250.
Any other thing clinically other than tachycardia, low blood pressure, whatever you said, and tachypnea? What else you will find in this patient who is obtunded? What else? Very
Ma'am,
typical.
dehydrated, dry mucous membrane, sunken eyes, dry tongue.
Would you look at the urine output?
Yes, yes, yes.
So you have now your laboratory investigation has gone and it has come. So how will you now have a confirmed diagnosis of diabetic
Okay.
ketoacidosis?
Ma'am, serum ketone is very reliable, which can, and
So you have got a urine report as well as a serum report of the ketone bodies.
Hmm.
Okay. And then, so now, how will you proceed with your management of this patient?
Okay.
Will you take this patient to the ICU or will you keep this patient in the emergency ward? You said you would keep observe the patient in the emergency ward. But I would suggest that you take this patient to the ICU. Will you tell me why this patient would be needing ICU requirement?
Ma'am, as per classification, according to the ABG, he comes under moderate DK. DK is classified into mild, moderate, and severe. So, as he is in moderate, he needs to be, and he's drowsy, irritable. So he might deteriorate. So, if he's not being managed properly, he's already dehydrated. He might land up into AKI also. So he needs a close monitoring and prompt action.
So, what would what would you expect your laboratory investigation reports to show? What are the other investigation reports that you would be looking into?
Okay. Serum electrolyte. Patient may come with dyselectrolytemia. And serum creat can be
So
at a
which
higher level.
electrolyte? Hi, sorry to interrupt you. I'm Dr. Akhilesh Tandekar. I'm your
Yes.
co-examiner. Dr. Rekha, hi. Good evening.
Yes. Good evening.
So, yeah, Dr. Shalini, what sort of electrolyte deficiencies do you find in these patients with the DK?
Potassium.
Potassium, what will be the potassium levels, increased or decreased?
Sir, you mildly low, sir.
Low.
Yes.
Why potassium is low in these patients? What could be the reason for low potassium?
Dehydration, and patient might have nausea and history of vomiting. So in that case, also potassium levels could be low.
Yes, it is due to the vomiting and excessive diuresis. So
Yes.
there will be loss of potassium. How about sodium levels? What will be the levels of the sodium?
Sir, it would be decreased as as increase in the glucose level. There is a decrease in sodium, so my patient can come with hyponatremia, sir.
Do you know any ratio? If the sugars are 600, what are the likely sodium levels in
Yes,
this
sir.
patient?
And after 100 milligram per DL, if every increase in 100 milligram per DL, there's a decrease in 1.6 mole of sodium. So
Okay.
in case of 600, if you're saying so, 5 into 5.6, 6,
I would just interrupt one. Yes, that is
7
correct.
to 8.
Yes, I would just interrupt Dr. Akhilesh. If you are saying patient is having acidosis, why were you saying that the patient, what is the expected potassium level?
Um, Mildly elevated potassium levels.
Okay. Okay, carry on, Dr. Akhilesh, please.
Yeah. So basically, yeah, electrolyte disturbance is very, very common. In DKA patients, these patients will have hypokalemia, whereas patients with the HONC, hyperosmolar non-ketotic coma, the potassiums may be relatively near normal. Okay, that is how you differentiate. Another thing that you need to see in DKA patient is these patients will be severely dehydrated. The volume depletion in DKA patients will be around 3 to 4 or 5 liters, whereas in HONC, the fluid deficit is around 6 to 8 liters.
8 liters,
So,
sir.
yeah, so the HONC patients will be more severely dehydrated.
Profound dehydrated.
Yeah, they will have profound dehydration. Any differentiating feature or differential diagnosis that you can think about in this patient, and what was the precipitating factor for
Sir,
this patient's decay? I think Dr. Rekha asked you this question, but you did not answer. What was the precipitating
Sir, this
factor?
Sir, in this case, in X-ray we found a right lower zone haziness. Also, patient came with a complaint of cough with expectoration. So, in this case, most probably it would be with pneumonia, which is a precipitating factor of the DKA.
Yes. Fantastic, fantastic. I think DK is precipitated by some sort of either infections or patients
Trauma,
with
surgery,
trauma,
sepsis,
surgical stress, or even patients with
pregnancy,
myocardial infarction.
ischemia,
Even in pregnancy or stroke can
stroke.
also precipitate decay. So, while treating decay, we need to treat the precipitating cause. Otherwise, you will keep giving fluids and insulin. The primary problem, if you're not sorted out, so the decay will keep persisting and you will keep treating this patient endlessly. So you need to treat the primary cause, whatever may be the primary cause. In this case, pneumonia. So probably the treatment of infection is the hallmark of treatment of decay in this patient. Apart from this, any other differential diagnosis that you can think about in this patient apart from pneumonia, and decay? What sort of differential diagnosis do you think about in this patient? So whenever in exam you present a case, I think you should have some sort of differential diagnosis that you should have. I hope Dr. Rekha agree with me on this. Uh,
Uh,
Madam, you agree with me? Yeah. What sort of a differential diagnosis do you have in this patient? Your patient is often dead. Okay. So do you think of any other differential diagnosis apart from DK or pneumonia?
uh, sepsis with sepsis can be uh,
Well, for sepsis, is your
Yeah.
patient hemodynamically unstable or
but
does he
he
have
is hypotensive. My patient is hypotensive.
patient is hypotensive? The sepsis may be one differential diagnosis. In this case, pneumonia. Any other differential
The
diagnosis?
starvation can be one of the cause because he was under
Starvation
stress and
ketosis. Fantastic. Starvation ketosis. Any other differential diagnosis?
sir, alcohol intoxication can also be
Alcohol
precipitating.
intoxication. Okay, young boy, it is not expected, but things are changing. Now young individuals are also consuming alcohol, so that is also one probable diagnosis. Any other differential diagnosis?
Um,
You
Acute
said your patient GCS is also low.
CNS infection, but neck rigidity was absent in this patient, sir.
Okay, meningitis. Okay, cerebrovascular accidents, intracranial bleed.
Bleed.
Okay, these can
22-year
also,
old, yes, sir. That's why.
you never know. Okay,
Yes, sir.
there may be aneurysm, there may be a malfunction.
Yes, sir.
Okay, there may be encephalitis, encephalopathy. So, all sorts of tumors. Okay, all these
Same
sorts
the
of
ICP.
differential diagnosis you may have to think about. Okay, yeah, Dr. Rekha, I would request you to take this
Talked
question.
about
Sorry.
precipitating
Yeah,
factor, about malaria. There is something else also in this particular patient, you said. Apart
yeah.
from, so two, three reasons that contributed to this. One is definitely precipitated by pneumonia. Then you also
Uh,
said another important point, which is very common in patients with diabetic ketoacidosis. Most of the,
uncontrolled sugar, poor insulin compliance, poor
yes,
compliance of
yes,
insulin.
it's a very common cause.
Yes.
And hyponatremia related seizures. No, these patients may have seizures. Okay, that can also be a contributory factor. In our Indian setup, tuberculosis, meningitis,
One
you
think of
know,
tropical
cerebral malaria, cerebral
cerebral
malaria.
malaria. These are very common causes. Okay,
Yeah, of
with
course,
fever,
it's
Yeah.
no history background, diabetes, fever, and unconsciousness, you should think of many febrile illnesses that are
Yes.
associated with consciousness.
this
So,
tropical
Then,
Dr.
illnesses
Rekha,
also you
yeah,
can think about. Yeah.
Dr. Rekha, Dr. Asif, if I can come in,
Hi,
Doctor,
Dr.
yeah.
Asif. Hi.
Good evening, good evening. Now, I've been
Yeah.
listening now since we are very nicely going on. I think now, since we're talking about a differential, if I can just comment, Dr. Shalini, I
Yes.
think one is a DKA that you have come to a diagnosis, but there would be a
Yes.
very strong differential in terms of an HHS out here.
yes.
Okay. So you have talked about what are the causative factors, what are the different possibilities, or what are the precipitating causes. But I think we also need to differentiate here at this point where we are talking about a differential diagnosis and a workup of this patient. You should know whether this is in a hyperosmolar hyperglycemic state also or not, HHS.
Sir,
So
his serum osmolarity
yes.
was
So I just
300.
tell you. So here, let us know how would you differentiate between the two in this period only, we're going to diagnose it and then subsequent management.
Okay, sir. So in DKA, blood sugar levels are ranges between more than 250 to 600. In HHS, it is more than 800, or 600 to 900 is the range. Serum osmolarity is higher, more than 350 in HHS, and while not, it is between 300 to 350 in DKA. So in sodium bicarbonate levels are in HHS, they can be near normal, while in DKA it is less than 15, and pH values are it's normal in HHS, while it is less than 7.3 in case of DKA, and anion gaps is higher in is more than 12 in DKA, while in HHS it
So
can
can
be.
you name also which one you will see in predominantly in type 1 and which one you will see in predominantly in type 2?
Right.
Sir, sorry, I didn't get the question, sir.
So
What type-
type 2, sorry, you said honk. So in which group of patient you will see, whether type 1 diabetes or type 2 diabetes?
Sir, HHS with type 2, more
Okay.
in elderly, while DKA is more common with type 1, or sometime with newly diagnosed type 2 also comes up with DKA.
Yeah.
Oh, yes,
Uh,
that's
yeah.
fantastic. That's fantastic.
So, yeah, Dr. Shalini, for the knowledge of all, if I can come in, Dr. Akhilesh and Dr. Rekha? Yeah.
Yeah,
So,
please.
yeah, one thing we need to know, in fact, for all the other trainees, that we have to be very careful in the history part, because HHS, honk will develop over a period of time. It could come
Chronic.
over days, weeks. Yeah.
Yes.
Whereas DKA would be very acute with the
Acute.
precipitating factors that you have talked about in a very short period of time.
Yes.
And the second part is you talked about the acidosis. Yes, the acidosis is not so very significant in HHS, whereas it is very significant in a DKA. But in terms of symptoms and history taking, you will find that the neurological symptoms are much more pronounced in an HHS.
HHS, yes.
Yeah, as compared to DKA. DKA,
Yes.
you'll get more of hemodynamic instability, you'll get more of your acidosis, ketones being high, very low bicarbs being there. So we just have to also consider all these points while taking it. Please go ahead, sir, ma'am. Go ahead.
So now that you are having DKA in this patient, so what was the blood glucose level in this case?
It was 350, around 350 milligram per
How do
day.
you go about with the management of this patient?
Ma'am, initially we have started volume resuscitation, because in DKA patient has come with profound dehydration, so we have to maintain volume, we have to expand volume, and it helps in many ways. It regulates sugar, blood sugar.
How will you expand volume? How will you expand volume? Which fluid you will give?
We can choice of fluid is 0.9 percent of normal saline. Will start in DKA. We'll start with initial 15
So,
to 20.
Yes.
how much fluid? Yeah.
15 to 20.
Depending on
we'll start with 15 to 20 ml per kg, and then we can here we give after that with IVC guided and volume guided, after once we have resuscitated with initial resuscitation. And then we started with insulin infusion with a bolus, with a starting dose of 0.1 unit per kg as a bolus, with infusion of 0.1 unit per kg per hour.
When do you start how do you start the insulin? And when you are giving this fluid, you look at certain endpoints.
Urine output, we have to check hourly urine output, and IVC, right? Blood gas.
Yes, you are looking at IVC output.
Blood gas. Yeah.
Clinically, what would you see in this patient?
Clinically.
Just as you said, urine output should be adequate, and then what else? The basic vitals, you don't have to check those.
Blood pressure, GCS, is it getting better? Hemodynamically,
look at your heart rate. Patient is whether the patient is getting hemodynamically stable or not. Those are
stable.
the things that you need to look when you are doing a fluid resuscitation of a patient. Okay. In
So there are
addition,
several ways to monitor the adequacy of resuscitation. As Madam has already said, the tachycardia, blood pressure, the
Urine output.
mentation also will improve. If the patient is altered, the consciousness should improve. The capillary refill time should improve. The best parameter is urine output. You should monitor urine output, and urine output should improve. And you have other ways to assess the patient's fluid responsiveness. You have CVP. You can see the rise in CVP. You can also consider other static and dynamic parameters. Okay, dynamic parameters, you place an arterial line and you see the pulse pressure variation. If the pulse pressure variation is improving less than 13%, probably the patient is improving. Capillary refill time less than 2 seconds, urine output. And if you have 2D echo, you can also see LVOT, VTI index, and IBC, collapsibility in spontaneously breathing patient. And if the patient is ventilated, IBC distensibility can also be seen. So we have to judge the adequacy with different markers, and it has to be personalized care. We cannot have a blanket statement like we should give this much fluid or that. You need to have some end points, and you should achieve the goals. So whenever you give fluid, your goals are hemodynamic improvement, okay, and urine output and all that, and your endpoints also should be assessed. Okay, so you need to also calculate the fluid deficit, how much fluid deficit your patient has. There are different formulas that you can also consider, because here you will also have to correct sodium. It's not just the fluid, but you will also have to correct sodium. You will have to use this adrog medius formula, which will help you to find out how much is the sodium deficit. And with that, you will also be able to calculate how much is the fluid deficit, and you will have to correct it over 24 hours. So sudden fluid resuscitation may be hazardous, can cause fluid overload, pulmonary edema. So that entity also you will have to assess, because you will have to keep monitoring saturation. At any point of time, the saturation is dropping. It means there is fluid overload.
Pulmonary
Okay.
edema.
So small fluid challenges, and then maintenance fluid also should be considered. And at the same time, you will have to start insulin infusion. And while you are giving insulin, your sugar targets are also very important. How do you titrate the sugar levels?
So
What are your goals?
we expect a reduction of 50 to 75 milligram per DL.
Mm-hmm.
And our target blood sugar, it should be hourly like this. But if blood sugar once comes below below 250, then we have to start a piggyback of 5% dextrose with insulin infusion in order
Yeah,
to.
absolutely. Absolutely. Your target is to reduce sugars by 50 to 70 milligram percent. But if the sugars are dropped by more than 100 milligram per hour or so, you will have to
We
reduce
have
the
to
insulin
titrate
infusion. You will have to reduce the insulin infusion to
to
half
half
and
0.05 unit per kg per hour.
yes, and make sure that the sugar levels are gradually reduced. Sudden reduction in the sugar level will lead to osmotic shifts, and
Cerebral
patient may
edema.
develop cerebral edema.
Yes, sir.
Okay, and then hyponatremia also has to be corrected gradually. Okay,
Yes.
so your target will be to not to correct sodium by more than 10 milliequivalents in 24 hours, of something like that. If the patient is severely hyponatremic, the
Mm.
sodium correction also has to be very, very stepwise. Okay, and at the same time, apart from your fluid or and sugar control, any other thing that you would like to manage? So madam had asked that question actually. Over to you, madam. Yeah, please go ahead.
yes.
So
So once you
yeah.
see that the sodium, what monitoring will you do during your process of resuscitation with normal saline, with insulin? What monitoring would you continue, and how frequently would you do?
Okay. Ma'am, we will get hourly RBS, random blood sugar, and hourly urine output should be seen. And we should get a consecutive 2 to 4 hourly blood gas in order to see the pH level, electrolytes, and we can get a serum ketone value also, repeated serum ketone values in order to see if it is decreasing. And
Yeah. So that's very important point that you have come up with. You would like to monitor ketones
What are
and
the,
all this.
so what
So
is
how
the
is the reliability of these ketones? Would you like to go guided by the ketones, or you would like to have any other parameter which will help you to assess the adequacy of the control of the DKA? And which sugar you, ketones you will monitor, whether you will monitor urine
Serum
ketones or
ketone
serum
is
ketones. Why
serum
serum
ketone.
ketones and why not urine ketones? Yeah.
Sir, because beta hydroxybutyrate is it is converted into acetate, acetoacetate, and acetone in urine. So it is at the so it is the highest number of ketone, the body which is present in the blood. So we go for it is more reliable beta hydroxybutyrate.
and
Yes,
moreover
I,
continues to be positive also, no, for a long time.
Yes,
Even
yes, 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 ma'am.
yeah, I would like to reiterate here, the fallacy of ketone test, basically, so this ketone test is done with the Rothras test. I hope you are aware of the Rothras test. So this
Yes.
Rothras test can only calculate acetoacetate and sorry, it only calculates the ketones. And probably some amount of acetoacetate. But
Mhm.
while you are resuscitating this patient with fluids and insulin, this acetoacetate is converted to beta hydroxybutyrate, and then butyrate is converted into acetone. And then your Rothras test can only measure this acetone. So when you resuscitated the patient, initially the acetone may get cleared off. Okay,
Mhm.
while the acetoacetate to beta hydroxybutyrate conversion is happening, that is not assessed by the Rothras test. Okay, so you can't completely rely on these ketones, whether it
Okay.
is serum or whether it is urine
Urine.
ketones. The only most and the most confirmatory test to assess the adequacy or control of the decay is to chase the anion gap. Okay, you have to chase anion gap, and only the closure of anion gap or normalization of the anion gap is the only definitive way to assess, whether your decay is under control or not. So
Okay.
I think most of these centers we keep monitoring. It's not bad that we should not monitor urine ketones or serum ketones. We should monitor provided it is positive. But if it's negative, we should not completely rely on that. Negative ketone test doesn't rule out the DKA control. Okay, so simultaneously we'll have to monitor DKA, which has a better sensitivity and specificity as far as the control of decay is concerned,
Okay.
probably. Yeah.
Yeah, Dr. Akhilesh, thanks. I think just want to chip in Asif here again. So
Yeah.
I think for everyone, all points that you have said and Rika ma'am said, I think absolutely valid, and we need to be very careful about it. Dr. Shalini, you also need to be careful of the term use glycemic diabetic ketoacidosis. Have you heard of it?
Yes.
So
Yes, sir.
this is a condition where people tend to kind of miss it or kind of ignore
Yes.
it, but you have to be very careful that in
Yes.
these patients you might get a normal sugar level and there won't be any reason for the metabolic acidosis except that the underlying insulin deficiency, which leads on to
Yes.
a euglycemic state. But this
Yes.
is more common with SGLT2
Two
inhibitors,
inhibitors.
and you can get it also in certain patients in the
Pregnant,
postoperative once
alcohol
they are stabilized
abuse,
ICU. Yeah. So
and
you have to be
glycogen
careful here.
storage disorders.
So here you have to go by exclusion of the different causes. You have to go by the severity of the acidosis, which is not explained by renal dysfunction or any of the other causes of a high anion gap, metabolic acidosis and AHMA. So that is something which we need to keep in mind, and the therapy would remain again the same. But we can't miss it out just going by that the sugar was within normal limits, or I should not suspect a DKA to be happening here.
Okay,
Yeah,
sir.
yeah.
And as
Thanks.
far as the, when you keep chasing anion gap, you should also know whether it is high anion gap or normal anion gap or a
Mhm.
and at the same time, you must also chase your bicarbonate and pH also. They should
Yes,
all
pH
correlate.
values, bicarbonate values, and there are certain endpoints we have to of resuscitation. It should be blood sugar less than 200, pH more than 7.3, and soda bicarb more than 15, and anion gap less than 12. Yes, ma'am.
So if your sodium level has become normal, then how would you further continue with your resuscitation? Or what is the need to go for a transition in the fluid management? At what point would you go for a transition in your fluid management?
Ma'am, when patient
Continue with your 0.9% normal saline, whatever you're saying, continuously with the fluid resuscitation, or would you at some point go for a transition in your fluid resuscitation?
once a patient resume oral diet and we can stop IV infusion fluid.
But at some point, you may need to change your saline. You cannot go ahead with saline. You may have to change your choice of fluid and also
Acha,
how
ma'am, if patient starts having chloremic acid doses because of NS, normal saline, then we have to.
then at what point would you consider changing to other types of fluids? And in what conditions would you go choose what will be your choice of fluid at different point of time?
Basically balance salts, we can go with another balance salt solution, ma'am, with if patient is having hyperchloremic
So
acid
Dr.
doses.
Shalini, you can just hold. I think Madam is asking very important question. See, what you're getting here is a hyperglycemic or a hyperosmolar hyponatremia, right? Initially. So that's how it is. If you go for the
Yes.
hyponatremia and the hyperglycemia, that's how a DKA is coming. No, so now you said in the initial part, you're going to take care of the fluid replacement and the resuscitation. You're going to go with the 0.9% saline. And once you have done that initial resuscitation, be it a blanket order, like giving 1000 over 30 minutes and subsequently 1 liter again over another 60 minutes, or you take the fluid responsiveness and other hemodynamic parameters into consideration, and then you manage it if every facility is available. So at what point would you like to shift from 0.9% to maybe 0.45% or any other fluid? That's the question, ma'am, Dr. Rekha?
Yes, absolutely.
When would you like to change?
Change to
If
some other
any other-
sodium, if sodium values are increasing more than one
145.
yes, and if chlorides values are also
If the chloride
150, 1
okay, it's increasing. Okay. 120 or whatever. Okay, 110, 120, whatever. Then how would you change your type of fluid therapy?
Okay.
Would you look at some other parameters also then? Or just that sodium only? Other values?
We'll start
Definitely it calls for reducing your concentration of sodium.
sodium. We can even change to 0.45% of normal, half normal saline.
Yes. Would you not look at your potassium level at that point? Will you not look at your bicarbonate level at that point? Will you not consider taking into consideration your blood sugar level at this point? Am I audible?
Yes, ma'am. Yes, ma'am.
So if your patient is having increase in sodium, you may consider giving
Delta gap, we can.
You can think of giving 0.45% saline. But if your patient is also having high chloride, so
Then 5D.
Are there any other fluids you can think of?
The voice is getting because of others.
So, Dr.
Yes, please go
Shalini,
ahead.
madam is asking you, when you have given excess of saline, so how will you switch over to other salines or any other crystalloid that you would like to think about, and why? She's asking why.
Yes.
So, this is probably the
I'll
question.
just give you a clue. You are now thinking of starting with 0.45% sodium chloride. Okay. Now, but suddenly you found that your chloride has also increased. So would you consider changing to some other fluid, or would you still continue with 4-5% saline, no, sodium chloride? Is there a role of balanced salt solution here?
Yes, ma'am. Plasma light.
Yes. So what are the indications? How will you change your transition to other fluid? So how will you decide? On what criteria would you decide which would be your next fluid of choice? When your sodium is increasing and your potassium and your chloride is also increasing.
So basically, to simplify this, I would like to
But
reiterate
your
here.
dextrose has gone down to below 250. Would you consider giving at all sodium chloride, or you'll stop giving sodium chloride? You just give 5% dextrose solution.
5% dextrose now.
So what would you look into when you are giving a 5% dextrose? What other electrolyte would you be looking into?
What other electrolyte, Dr. Shalini? Yeah, in addition.
Potassium, magnesium.
Potassium is very important. Why? Why it is important at this point when you are giving dextrose infusion?
What?
It can cause hypokalemia.
Yes. And you are also expecting, with the correction of metabolic acidosis, your potassium level to be
Is
going.
already, yes.
So you can also think of giving balanced salt solution to this patient, or you can think of giving 25% dextrose if your blood sugar level has gone down, and then you can add potassium as a supplement. Okay.
Yes. Yes, ma'am.
So the best way to resuscitate a DKA patient is you initially start with 0.9% saline, normal saline. You give 1 or 2 liters of fluid. You cannot give more than that. Okay, because hyperchloremia is a problem. So given a choice, if you have because you want to replenish fluid. If you replenish fluid, the sodium levels will automatically come up, because when the sugar levels will come down, the sodium levels are going to come up
Automatically.
automatically. So it is not necessary that you give a particular kind of a solution. Your intention is to fill the patient. Your intention is to complete the deficit that your patient has. So any fluid that you give is okay. Normal saline has a problem because the chlorides will increase. Initially the patient will have high anion gap. DKA patients present with high anion gap, but when you give excess of chlorides, that high chloride will lead to normal anion gap, and you will get fooled by the fact that the anion gap is
Is
normalized, the
normal.
patient's
Yes.
DKA is
Yes.
controlled. So you need to take it with a pinch of salt. Even if there is a normalization of the anion gap, just look at the chloride. So that normalization of anion gap is probably due to the high chloride levels. So you have to switch over that fluid from normal saline to half strength normal saline, or half strength saline, or you can go ahead with the 5% dextrose. So 5% dextrose will try to control the intracellular dehydration, because these patients will have intracellular dehydration. You need to correct it with the 5% dextrose, and that is possible only when you brought the sugar levels up to 250 or 200 or something like that. You should try to supplement the glucose. 5% dextrose or even half strength DNS solution can also be given, because the tissues has to utilize the glucose. If you only keep giving normal saline, the tissues will not be able to utilize glucose, because you are giving insulin, and if the glucose as a substrate is not available, the tissues will not be able to utilize that glucose. So that's why when you bring down the sugars from 500 to 250 or something like that, you should supplement it with 5% dextrose or half DNS or something like that, so that the tissue related glucose uptake can also be enhanced, and your intracellular dehydration also will be corrected at large, and the acidosis will also be corrected. Okay, so these are the important facts that you should remember while you resuscitating the patient. Fluid initially with balanced crystalloid or even normal saline, it doesn't matter. Okay, Dr. Rekha, sorry I have interrupted you.
Oh,
Please,
it's
you can
fine,
go ahead and
fine.
take questions. Yeah,
Fine. You can add
Rekha
some.
madam, yeah.
So you are continuing to monitor your electrolytes every 2 hourly or 4 hourly. And what is the time now that you think that your blood sugar has come to normal and your electrolytes have also come to normal? Okay. And then switching over to other forms of insulin
Again,
therapy. The
again,
patient is.
can I add, in these patients, even if the potassium levels are supposedly normalized, okay, if you have seen that potassium levels are 4 or 4.5, in spite of that, you need to keep correcting that potassium, because the potassium is intracellularly most of the times. Okay, so due to this, decay, there is a tremendous loss of potassium from intracellular space. So, in order to maintain the potassium, levels intracellularly, you have to correct the potassium levels. You may have to overcorrect as well, and try to keep the potassium of around 5 to 5.5 or something like that. Then only the potassium will get corrected. And the potassium correction is not going to get completed unless you correct magnesium levels. These patients, DK patients, will also develop magnesium deficiency. These patients will also develop magnesium deficiency. And if the magnesium levels are low, no matter how much potassium
Calcium
you,
supplement.
yeah, how much potassium you give, that is not going to be corrected well. So that's why your concomitant magnesium correction also should be there when you are correcting potassium. And that is
Rick-
what is very important. Yeah.
yeah. Rekha,
Ma'am,
ma'am. Yeah, sorry, Rekha, madam. I think Dr. Shalini here, since we're talking about that anion gap, I think the role of anion gap, along with that, you have a gap analysis. So that comes into very much of an important role. Like suppose you had an HAGMAN, high anion gap, which is typically seen in a patient of DKA. But once you have treated this patient, what we were just discussing a little while ago, when you have given too much of 0.9% saline and the chloride starts to rise, you get a hyperchloremic metabolic acidosis. So what will happen? Your gap ratio here becomes less than 1. Ideally, it should be just equal to 1. But when you get a normal anion gap, in addition to a HAGMA that was there, so basically a hyperchloremic acidosis now setting in the background of your DKA, that time when your gap analysis gets less than 1, you have to suspect this. That would be another indicator where you have to switch over to other fluids rather than 0.9%.
Yes.
Ma'am, please go ahead, ma'am.
Ma'am, you
hyperchloremic non-anion gap metabolic acidosis. Okay.
Mm.
So that condition is very important. That is what actually I was asking you at that point of time.
Okay.
Because chloride can be up and yet you will be getting a picture of normal anion gap.
Yeah.
But metabolic acidosis continues to
Okay.
persist. So, and having said that, now suppose your patient is not getting up. Okay, your patient is still obtunded. What probability? What is the probability of mismanagement in this patient regarding fluid management or anything during your management? You have done some mistake for which the patient remains obtunded.
Patient may land up into cerebral edema or it can be a matlab, which can be the contributing factor of obtundation, matlab rapid correction of sodium or cerebral edema over because of fluid over rapid correction.
Free fluid, lot of free fluid. You have
Yes.
administered lot of fluid, and then
Hyperglycemia can fall.
correction of hyperglycemia.
Yeah, if may patient would have landed up into hypoglycemia, that can also be one of the mistake.
Very good. And another thing, sometimes it happens in HHS. Sodium gets overcorrected and then you are trying to correct it with administration of 0.45%. You have infused too much.
Close karo na, Pooja, please door band karo.
How will you manage this patient? How will you manage this patient?
Okay.
And what are the adverse effects that it can land up in if it is not identified and managed? Did you hear me?
Actually, it's not audible. Sorry.
Now,
Yes, now it's better.
See, suppose your patient, you have corrected your patient, you have given fluids and everything.
Yes.
But the patient is not getting up from the coma. If the patient has
Yes.
gone coma.
Yes.
So what's the possible mismanagement that could have occurred during your course of fluid therapy or the type of fluid therapy?
Rapid correction of sodium, rapid correction of sudden shift of fluid from the extracellular over resuscitation of fluid, sudden shift, cellular, transcellular shift may cause cerebral edema or osmotic demyelination syndrome can also.
What are the electrolytes and what are the levels that you need to look into when you are correcting, and how you are correcting also, it is very important. So what are the You are correcting your blood glucose, you are correcting your sodium, isn't it? Am I audible to you?
Yes, ma'am.
So you said a sudden correction of your hypernatremia.
Yes,
Okay.
yes,
Blood glucose also, if you have corrected your blood
yes.
glucose very rapidly, most commonly
Rapidly. Yes,
in HHS, particularly, it is more common in HHS where the blood sugar level comes down from a very high level to a normal level in a short period. Similarly, your sodium should not also be corrected. There is a limit over a period of which it should be corrected. So these are the probable reasons. So how are you going to manage if this is if such a thing has happened, your patient has gone into a coma or patient is having seizures?
mannitol. We can give any anti-edema measure. We can start with anti-edema measure mannitol or 3% mannitol.
Suppose when will you give 3%? Now you tell me when you will give 3%. How will you decide whether you should give 3% in this particular patient? In which scenario will you give 3% since you have already uttered that?
If patient is already dehydrated, we cannot give mannitol. It will again cause diuresis.
You have overhydrated your patient.
Okay, okay.
That has caused cerebral edema. That is a situation where you give a 3% sodium chloride. Otherwise, you would prefer a mannitol.
Okay.
Rekha ma'am, if I can come in. So can we
Sure,
another
sir.
10 minutes, ma'am? 10 minutes more?
Yeah.
Okay.
Can you go ahead with your case further ahead? I think we have not seen your slides further ahead. So
So
can you
that was
proceed?
that was all case summary I have.
Okay. So how did you treat your patient's infection? So how was it treated? Your patient also had pneumonia. So how
So
did you
we have
treat?
started with third generation. We have started with antibiotic and
Which antibiotic did you give it to your patient? You gave third generation cephalosporin.
yes,
What was the finding in this sputum culture? Did you see any growth of organisms?
sir. No growth was there.
So then, what was that pneumonia? Was it viral, bacterial, fungal, or what was the cause? How will you differentiate that fungal, viral, or bacterial infection? Or
Sir, sir, we go with the cultures to find out the organisms.
so your patient serum, CRP and procalcitonin. How was the serum CRP and procalcitonin?
CRP was raised. It was 2, 13
So
was the CRP and Procal was also more than 2.4. It was more than 2.4.
so what could be the cause of pneumonia in your patient? Did you pinpoint this?
Community
You-
acquired pneumonia can be the cause. He was
So,
bacterial.
so what are the organisms that are involved in community acquired pneumonia?
Streptococcus mm,
Mhm.
Klebsch, Pseudomonas.
So you can have streptococci, you can have H influenza,
Yes.
you know, but this Klebsiella and Pseudomonas that you were uttering, these are mainly hospital acquired infection, nosocomial
Yes.
infections.
Yes.
Your
Yes.
patient directly came from home to hospital, so it is very likely that it may be a community acquired
Acquired
infection.
pneumonia.
If this patient would have visited hospital on several occasions, then you would have considered probably healthcare associated infection or hospital acquired infections. So these patients are generally sensitive to third generation cephalosporins, and you may have to add, atypical cover,
Yes.
maybe clarithromycin or azithromycin, or maybe levoflox or any aminoglycoside can be added. Especially if the patient has pseudomonas. Nowadays, we see pseudomonas in community infections also. So for that, you will have to give dual antibiotics, BL-BLI combination with aminoglycosides or any respiratory fluoroquinolone would be an appropriate antibiotic choice, and you should give it for at least 5 to 7 days. And later on, you should probably go clinically and if you have a facility, you can follow up the cultures. But what I wanted to emphasize here is the treatment of infection is very important. That's why you need to identify whether it is community acquired, healthcare associated, atypical. So your antibiotic should be targeted to what type of pneumonia you're dealing with. Otherwise, you may have failure of the treatment if it is hospital acquired, and if you keep giving third generation cephalosporin and treating like community acquired pneumonia, the DKA may not settle down in spite of fluid therapy or insulin therapy or glucose control. The infection will keep triggering the decay. So that's why the prompt treatment of these patients, as far as the infection is concerned, is very very important. So that's all from my side. I hand over to Dr. Rekha, madam,
I think
and
we are almost,
Dr.
yes,
Asif. Yeah.
we are almost done.
Yes,
And
ma'am.
I will just ask you, is there a role of bicarbonate in the management of DKA? Since we are
Ma'am, they
talking
are
about
it's a very matlab it is a all it was a point of discussion that whether it should be given or not. There's no very much clear cut indication, but they say but we can give it, when pH is less than 7.1, or there was one more indication.
7.1 or even less.
Hyperkalemia is also, in hyperkalemia also we can give sodium bicarbonate
Okay.
when
So
it
the,
is more than
so the
6.
only indication for soda bicarb is if the pH is less than 7.1, okay, or the bicarb is less than
Yes.
15, or in a
Or potassium is
or
also
Normally we
potassium
don't
is very high
normally
levels.
we don't give with the bicarb less than 15, or it is less than if the metabolic acidosis is getting corrected. But if there is a persistence in spite of management, if your metabolic acidosis persists and bicarbonate continues to be below 15 and your pH continues to be somewhere around 6.9 and doesn't get corrected above 7.1, maybe you can think of giving bicarbonate.
But at the same
Absolutely.
time, we need to treat the primary cause also while treating with the bicarb, because bicarb correction is not the definitive intervention that you are
management.
aiming at.
Yes.
So your definitive intervention is control of infection. Because in this uncorrected situation, if you keep giving bicarb, that will be like a double-edged sword. Okay, it may
CO2 will rise, it may, and patient may land up into more mental
Yeah,
op-
so that is also there, and that may cause trigger more of anaerobic metabolism, because oxygen dissociation curve will also be
shifted.
shifted to the left
Mm.
side, and then there will be tissue hypoxemia. Okay, so soda bicarbs should be given with pinch of salt, only in a desperate measure when you have dangerous hyperkalemia or a pH which is going below 7.1, which is causing a lot of acidosis, and that acidosis is causing arrhythmias. Probably these are the indications only where we can support with the bicarb. Otherwise, bicarb should not be given routinely unless the patient is a known case of a CKD or something like that. Yeah,
Okay.
Right.
that's all
The
from my
same
side.
stands, yeah, Dr. Akhilesh very rightly said, the same stands for your phosphate levels. People do monitor phosphate, but correction or giving a phosphate infusion, in fact, it has not been found to be beneficial or having a lot of
Mhm.
good effects there. So that's okay. We can monitor it, but I don't see that as per the guidelines or recommendations. We always need to correct the hypophosphatemia that's occurring in these patients. So,
Okay.
yeah.
As hyperosmolar honk is associated with progressive progression of the acidosis. These patients will have nutritional deprivation. They will have a lot of deficits. Electrolyte deficits. They will not be eating, drinking well, so they will be dehydrated, and they will have phosphate deficiency. They will have potassium deficiency, magnesium deficiency. All sorts of deficiencies are there. You can see in these patients. So that's why you need to correct these deficiencies, whether DK or honk. The nutritional supplementation is very very important. You have to start gradually feeding these patients. If the patient is chronically malnourished, then there may be deficiency of these electrolytes. The refeeding syndrome can also be precipitated, because already the electrolytes are low, On top of that, when you start feeding these patients, there will be sudden shift of all these electrolytes intracellularly. So that may trigger or worsening of the electrolyte disturbance, especially hypokalemia, can be uncorrected. Especially those patients who are not eating, drinking well, malnourished. Okay, and you try to feed them suddenly, and you will see that you are correcting these patients with potassium one after the other, and you're given excess, maybe 100 milliequivalents, 150 milliequivalents of potassium has been corrected, but it still not is getting corrected. Think about repeating syndrome also as a possible cause of undercorrection, with even in spite of the best corrective measures. So that entity also we need to look at it. Yeah.
Right.
Sure.
Right. I think quite a healthy and quite a elaborative and detailed discussion. Thank you so much, Dr. Rekha, Dr. Akhilesh, Tanikar, really taking us forward. I think the trainees would have had a lot to learn and a lot of clarifications done and insights as to how the right approach should be. We have always been given what are the different possibilities, but how to approach the right way, that's very important. Thank you, Dr. Shalini, for having
Thank you, sir.
quite
Thank
a
you, ma'am.
marathon examination done. I think very well managed and very well answered too. And would like to thank all the participants who are there and all the organizers of this event. So with this, we
Thank
end
you.
the session and good wishes to all. Thank you so much, Dr. Rekha. Yeah, ma'am,
Thank
please
you.
want to say something?
Asif Ahmad and Dr. Asif Iqbal, both of you, and my co-examiner, Dr. Akhilesh, and
Hello.
good work, Shalini. You must actually remember, actually, this was a very healthy discussion about all the electrolytes. So what Akhilesh said about hypophosphatemia, the likelihood of occurring, you must read them thoroughly, because these things also are asked. What other electrolytes you need to monitor? Phosphate,
Okay, ma'am.
right? Okay.
Thank you,
Sure.
ma'am.
Thank you
Thank
all
you.
once again.
Thank you,
Thank you, sir.
madam. Thank you, Dr.
Thank you, ma'am.
Asif.
Thank you, Dr. Akhilesh. Thank you,
Thank you,
Dr. Rekha.
everyone, all the doctors present. We also have some question in the chat box.